Catherine.
Yes, yes.
You did not give me permission to mute. There's
Oh,
a lot
okay.
of
Thank
people
you,
that have
Barb.
to be muted.
Right. Okay. Okay. Barbara is here, and Barbara is joining me today. Barbara works at the Care to Caregivers helpline with me, and she's going to help if anybody we hear background noise from anybody's computer. Barbara is going to help, and she'll mute you. So I definitely will be asking you questions. So I really welcome your participation. You can type in chat with your responses, and if you can be very brief, you're welcome to unmute yourself and to share that as well. So, I have a jam packed session for us here today. There's so much information to cover here. We're really going to be scratching the surface. So, if anybody has any additional questions or concerns, I'm going to hang on after our webinar so I can address those for you as well. And then you can always call us here at Care to Caregivers, and Barbara's here. I'm here, Rita and Edna, we're all here to help you figure out the particulars of your individual situation. So welcome to our webinar on understanding dementia and memory loss. My name is Mary Catherine Lundquist, and I work at the Copsa Institute for Alzheimer's Disease and Related Disorders at Rutgers University. And we've been around for over 50 years, and we provide support for individuals and families who are dealing with aging and memory loss issues. We have a clinic in Edison where you can go and see our geriatric psychiatrists and geriatric social workers to get diagnosed, and then go back if your family member is having any behavioral issues like they can't sleep or they're really anxious or any of the things like that. And the doctors and the social worker can help you there. And then Barbara and Rita and Edna and myself, we're here to help you with everything else through our Care to Caregivers helpline. So we provide one on one telephone support. We email you if that works better for you. We'll do a Zoom meeting one on one for you if that works better for you. So we do these webinars to support you as well. And we have 10 support groups per month. So that's a great place for you to come and kind of connect with people who are walking in your shoes. And I know we have many friends here today who do attend our support. So thank you, everybody, for being here. So let's start to delve in here to understanding what's going on when somebody has dementia. I'm hoping by the end of our time here today, you're going to be able to list diseases that cause memory loss, because there are a few of them. There's just not one. You're going to be able to describe changes that happen over time. You're going to be able to talk about methods for diagnosing and for treating. And then by the time we leave, hopefully you're going to have one or two ways that you can kind of empower yourself as the caregiver as you are going forward. So, as we're getting started here, I'd love for everybody to pop in chat here and type for us, who are you caring for? Who are you caring for? How long have you been caring for them? I know we have people here who are probably supporting spouses, and we may have some other maybe adults who are taking care of their parents. So Dennis, his wife, and Michelle, her mother, close to 3 years, she has Alzheimer's disease. And many of us, it could be 3 years. Some of us, it might be a shorter amount of time. And for some of us, it might be 10 years. So my mother, Darlene, has her mother and her aunt. So two people, Darlene more than 5 years, and Yarma, his spouse. So it's a little bit different for everybody, right? Sometimes it can look a little bit different if you're married to the person or if it's your parents. And Beverly, my spouse, in September, it'll be 4 years, and he has Alzheimer's disease and dementia. And Claude, my wife, Mary Alice. So I'm just wondering, too, from our friends who are here, has a doctor told your family member has Alzheimer's disease or your family member has frontal temporal lobe dementia? Have you heard any words like that from your medical providers regarding their illness? No, Monica is saying no. Okay. And Yana is sharing that she thinks her dad is starting to have signs too. And Michelle is saying no too. So how about some of our other friends? Has a doctor or medical provider, so Dennis is saying dementia, and Jean is saying no, not diagnosed yet. Loved ones not accepting the possibility. Very common, right? They think there's nothing wrong with them. That's a part of the syndrome as well. So, quite a few of our people are sharing that they don't have a formal diagnosis, and we're going to talk about why that's really important. And hopefully, you'll feel a bit empowered to go and get that diagnosis today. And Beverly said, I suspected it, so I took him to a neurologist, and he confirmed. Carla says, my mother diagnosed with frontal temporal lobe dementia and Claude not medically diagnosed. So we're going to cover this today. So you take what you learn from here today and then you decide what's going to be best for you going forward. I have lots of handouts for you too. I have a lovely handout that summarizes everything that we're going to talk about. I'm going to email that to you afterwards, so don't worry about missing anything. And Yarma is sharing 15 years in family history. We knew first. Yes, doctor. Get a letter because you need it. So, yes, it can be very helpful to have whatever the doctor's saying in writing. So, and now we should all have, I think it's the law in New Jersey, we should all have immediate access to that, to what our medical record is. So, good to go back and ask the doctor. So, sometimes they think we can't handle it or we're not smart enough, but hey, we are smart enough and we want to know. So, give it to us straight. We want the facts so we can kind of be informed about our own health and the health of our family members as well. So, wondering what everybody thinks. Aging and memory loss. Is it normal to have problems with your memory as you're aging? And you can type in chat and let us know. What do you think? Beverly is saying yes. How about some of our other friends here? Yes, normal to have some. Claude, yes. Dennis, yes. Darlene, I think some memory loss is normal. Jacqueline, yes. Monica, oh, we have lots of people saying yes. So yes, we can see some changes in our memory as we get older, but it's not normal to normally have significant problems with our memory. And that's really a part of the problem that we have here in the United States as, in general, is that people think that it is normal. So oftentimes when we are older, these symptoms just get written off. Like we say, oh, they're old, this is just normal and it's going to happen to people as they get old too. Well, it's not true because there are many people or more people these days are getting to live to be up into their 90s and to be 100 and their memory's pretty good. So they remember important dates in their past and they can still take care of themselves and make decisions and pay their bills and stuff like that. They might have some vision problems or hearing problems, because our bodies start to deteriorate. But the brain is an organ. And for many people, that organ can stay pretty healthy as time goes on. Now, that doesn't mean that there might be some slight changes. So the only thing that is kind of normal is that it might take us longer to retrieve information. That means if you're trying to think about, ooh, what was the name of the actor from that movie or, a person's name, um, we might be hard pressed to kind of come up with that immediately, but that probably comes to us at 2 a.m. in the morning or the next day. It'll kind of come back to us. And the reason for that is because the longer we live, the more information we have. I like to think about it like file cabinets. Those of us who are older, we know what file cabinets are, right? So the more information you have, the more papers, file folders, and the more drawers you need to keep all this information in. So if you get to live to be 90 or 100, you're going to have quite a bit to sift through to find that information that you're looking for. So it might take us longer to retrieve the information because we have more stored information. That is normal. It also might be normal for us to have a harder time multitasking. And that's not such a bad thing because now science is really showing us that it's not good for us to multitask. You really can't multitask. When you're trying to do that, it just means that you're giving poor attention to two things at the same time. So, but that can be harder for us to shift our focus rapidly from one thing to the other as we get older. So, but other than that, it's not normal to have problems with our memory. So we really want to hold on to that. And Carla is asking, is memory loss hereditary? Sometimes yes, sometimes no. For instance, with Alzheimer's disease, only a very small portion, and I might have the number wrong, but it's like 1 or 2% of the Alzheimer's diseases that are out there, and there are different variants of Alzheimer's disease. A very small percentage are hereditary, and those are the ones that a person would get prior to the age of 65, the early onset disease. So, but we all do have life factors that can impact how well our brain is doing. So things like heart disease, right? If we get have high cholesterol, high blood pressure, and it's not monitored, metabolic diseases, if we have diabetes, those things all put us at greater risk of having vascular issues and also inflammation in our brain. So we can do things about those things. If we can manage our heart issues, keep our heart healthy, manage any metabolic issues like diabetes that we might have, that can help protect our brains too. So that's kind of like a complicated way to kind of answer that, but we can look at our lifestyle. Sometimes we inherit lifestyle factors. Like maybe in my family, we never really exercise and we eat lots of fried and fatty foods. That's something that I'm inheriting that could increase my risk of developing a brain disease as I get older. On the other hand, maybe in my family, we eat a heart healthy diet and we walk every day for 5 miles. So I would be inheriting something that's really protective for my health. So we can inherit those things, which can impact what diseases we get later in life, including diseases that impact the brain as well. So, um, and Beverly is saying here that's the reason why some families don't realize it and the loved one gets diagnosed too late. Right, because it just people think that it's normal and it's not normal. So we always want to be looking into this. It's normal to forget where your keys are because we've probably all done that. So it's not normal if you're holding those keys in your hand to not know what to do with those keys. It's normal to get into the car and to have a lot on your mind and start driving in the wrong direction because you kind of forgot where you were going because you have a lot on your mind. But it's not normal to get lost going to ShopRite when you've gone to ShopRite for the past 60 years on the same route. So that's kind of the little bit of difference there. So chances are everybody who is here today, the person you're supporting has had some significant issues. So let's delve a little bit more into this as we go along. So now, sometimes an individual can have some memory loss issues, and it's a temporary type of thing. It's due to one of these issues that I have up here on the screen. And if we address what the issue is, the memory might improve. A big one that I'm thinking about is depression. Many times we can be prone to experiencing depression as we get older and we experience changes in our body and changes in our social situation and our housing situations. We might experience depression. Sometimes depression looks like dementia. It's not dementia. So, but if we get the depression evaluated and treated, the memory will improve as well. Many times people come to our diagnostic clinic and they think it's dementia, but we screen and treat for depression first. Do the screening, provide medication, monitor the person over a period of time. And if it's a true depression, when they respond to the medication, the memory improves and it is better. So, other things, sometimes medications we are on might impact us cognitively. If we have vitamin deficiencies, if we're really low on vitamin B12, and sometimes people are for lots of reasons, that can impact our cognitive abilities as well. If our thyroid is off, too low or too high, that can cause memory problems. If we're not getting the right nutrition, if we have diabetes and it's not controlled, our blood sugars are really high and our blood sugars are really low, we could have like a temporary cognitive altered status as well. There are lots of other medical conditions or maybe medical treatments that people are getting. medications that might impact their memory. A person could have a delirium, which is kind of a medical emergency when they're really kind of off kilter and having cognitive issues. And it might be related to any one of the things that we have up here on the screen. It could be lack of sleep due to sleep apnea. This is a big one. We've had people who aren't sleeping well and have sleep apnea, and they go and they get evaluated and they get the CPAP machine, and then lo and behold, they're finally getting good sleep and their memory has improved too. Vitamin D2, one of our friends is sharing here. Thank you for sharing that. UTI can cause a delirium. That's right. So sometimes there's a medical condition going on for us that is undiagnosed and it can cause an altered cognitive status. So, first step is always get all these things ruled out. And we do that by going to see a primary care doctor. So that's the first step. Before you can even go to our clinic to get evaluated by the doctor for Alzheimer's disease or something like that, you need to go to the doctor. You need blood work done, a urinalysis, and all that stuff so we can rule out all of these things. So once we rule out these things, if you're clear for all of these things and there still are memory issues, then chances are it is one of what we call the neurocognitive disorders. And these are the main ones here. Alzheimer's is the one that we hear about the most. 60 to 7 to 80% of the population who have memory loss issues, it is Alzheimer's disease. There's not one type of Alzheimer's disease. There's lots of different genes and different types of Alzheimer's disease as well. The next most common one is vascular dementia, and this means when we have a loss of blood flow to the brain. And that's either through a stroke, a major episode where we lose blood flow to the brain, or smaller TIAs, trans ischemic attacks. So, and sometimes people can have lots of those, and the impact of those is kind of cumulative, and we can see more damage in the brain as well. So, Alzheimer's disease, vascular disease, two completely different diseases. So, they all cause what we call dementia or memory loss, but they're different roots causing the dementia or the memory loss. Lewy body disease is another type of dementia, and the chemicals are different in the brain than Alzheimer's disease. Frontal temporal lobar degeneration, or FTD, that's a different type of a neurocognitive disorder. Some individuals who have Parkinson's disease may develop dementia. Not all individuals who have Parkinson's disease. Huntington's disease is another disease that strikes people when they're younger. Wernicke-Korsakoff syndrome. This is when a person may have had a long history of alcohol use and their body cannot process a certain chemical anymore, and then they are prone to experiencing this syndrome here. And many people may have a mixed dementia, and that means that it could be Alzheimer's disease and vascular disease, or maybe they have vascular disease and Lewy body disease. So sometimes it can kind of be a mixed picture for people too. So, and it's really important for us to kind of know for our family member what's the disease that is causing the memory loss for the person that I am supporting. We want to know about that. Dementia just means memory loss. Dementia is not a disease, it is a syndrome, it is a group of symptoms. And there's always a disease that's causing the dementia. So, another way to kind of look at it is when you have a fever, right? You always want to know what's causing the fever. Is it a viral infection or is it a bacterial infection? So why do you think that's important to know what's causing the fever? Any ideas? Type in chat there for me. And yes, Yana, while people are typing in chat there, the Wernicke-Korsakoff is due to long alcohol use because the body can't process, I think it's thiamine anymore. So yeah, yes. So why do you want to know when you have a fever, what's causing the fever? Is it viral or bacterial? Why do we want to know that?
Because the treatment's different.
Right, oh, Linda, thank you. Yeah, we need to know because if it's bacterial, we need antibiotics to kind of address that. If it's viral, Antibiotics aren't going to help that. It's the same way with dementia. You want to know what is causing it. As Gina's sharing with us, you need to know for effective treatment or intervention. Yes, so that's why if you don't know, encouraging you to go and find out from your medical provider. Now, what all of these diseases have in common here is that they impact the brain. These are diseases of the brain. The person's going to look normal from the outside. We are not going to be able to tell, but chemicals are going to come and start to be profuse in the brain. And for all the diseases, it's a little bit different what the chemicals are and how those chemicals kind of progress through the vein. If somebody has vascular dementia, it's going to be more pinpoint damage. If somebody has Alzheimer's disease, it's going to be more profuse throughout the whole brain. But as you can see here by our elementary diagram here is that parts of our brain control everything that we do. For instance, take balance and coordination. Maybe you have noticed this from the person who you are supporting. Many older adults with neurocognitive disorders will start to shuffle their feet when they're walking. They're not picking their feet up, they're just kind of shuffling along. And they might start to get hunched over a little bit more, like their back gets hunched and they're kind of looking down at the ground a lot too. And they might be unsteady and more prone to kind of losing balance and kind of tipping over. Has anybody here noticed that about their family member, that they have difficulty when they are walking?
Yes,
Okay, good. So that's related to an area of the brain. See back here, back by the brainstem, the green section down at the end here, balance and coordination. There's a part of our brain that controls that. So sometimes we've seen caregivers before hollering at their family member, pick your feet up. I keep telling you, pick your feet up. Really, your family member can't help it because that part of the brain is damaged. So, and it's like that for all of the other things, our language, our sense of direction, our smell, even those things, our ability to kind of appropriately socially engage with people in social situations. That's all controlled by our brain. Our ability when you pick up your coat to put your arm in the sleeve of your coat the right way. Our brains control that. Maybe you've noticed that your family member sometimes has difficulty. They have a hard time getting their clothes on right. Has anybody ever noticed that before? Our brain is controlling all of that stuff. So we have lots of comments in chat here. So I'm just going to go over these a little bit. Um, so, what do you ask for in knowing how to pinpoint dementia and its levels? Robert, hopefully by the end here, you're going to have that answer. Okay, we're going to go over all of that.
Thank you.
And Yarma is sharing UTI in the aged is
Mm.
different than in youth. You 100%. It impacts us a lot harder than it does when we are younger. And Darlene, we are going to talk about how all these diseases are diagnosed. We're going to go over that. And yes, as Yarma is sharing, like his wife is not standing or walking anymore. That can happen to many people who have neurocognitive disorders the longer they live with these diseases. And Dennis is sharing that his person holds on to me with both hands because they're really unsteady, right? That's because there are changes in the brain. And do you need an MRI to diagnose Wernicke-Korsakoff? Yes, you should definitely go to see a specialist, Yana, and they can recommend all the tests that you should get. It's going to depend on what person's age, how much you kind of want to put them through and what the doctor is saying as well. And Yarma is saying that all the love is still there. That's so true, right? And that's what we hope that we're able to hold on to, that, despite what might be happening with our family members, memory that we can still connect and be there for each other and love each other through these changes as well. So, all right. So, with all of these diseases, we know that, yeah, humor is important too. So, very, very important. So, we know that our family member with these neurocognitive disorders, they're going to have problems. It's just not memory, right? It isn't that we just can't remember things. We can't think properly, think through and solve problems. Our language be impacted. We can't find the words. We're not coming up with the right words. We might be saying words, but it really doesn't make sense. We could have changes in our personality. Maybe we were really sweet before, but now, boy, we are cranky all day long. Our judgment could be poor. We could be wanting to do things that are really not in our best interest, like drive a car when the doctor said we shouldn't and it's really not safe, or cooking, or we might be, giving our credit card number out to people who are calling us on the telephone or things like that. And we might have difficulties being oriented. So we might be in our own home that we've been in for 40 years, but we can't find the bathroom. So, has anybody ever noticed that before? Like your family member has a hard time getting oriented. So, these neurocognitive disorders, they can kind of impact us in many different ways. So, I'm just going to show a short little video here, and this is of a client. We used to have an adult day program, and we're going to look at language just for a brief minute here. So, I'm going to show you just a small portion of this.
Everyone has trouble finding the right words sometimes, but when people have dementia, their trouble with language is due to damage in a portion of the brain. As you can see from this image, there are several areas of the brain that are involved in processing language. A problem in any of these areas can cause problems with language. Sometimes people have what is called expressive aphasia, a problem expressing language, or receptive aphasia, a problem understanding language. In our scene, Janet is speaking. What kind of language problem do you think she has?
Janet, tell everyone what kind of trees you might have in your yard. Do you have a lot?
No.
You don't have a lot of trees? What kind of trees do you have?
Another common cognitive deficit.
So, as you could see from that, Janet was being asked a question and she really couldn't respond, right? So, maybe that's happened to you before. Have you ever asked your family member something and you're hoping they'll kind of engage with you in conversation and you just get nothing back? Has that ever happened to anybody here? So that can be pretty common because language can get impacted on so many levels. So I want you to remember that because we're going to come back to that later, okay? So and Beverly is saying yes, and Carla and Dennis says sometimes that happens too because there's so many, and there are literally like probably 30 or 40 different um, terms that we have to describe all the nuances of the language disturbance that we can experience as well. So, but this is just to give us an idea of how profuse like this damage can be and the impairment can be for the person across all the things that the person can do. We know that the individual may start to have changes in their mood. So, one thing is the person might become very apathetic, and that means they're just sitting in a chair all day long and they're not doing anything. Maybe they were pretty busy and active before and they had hobbies and they talked to people on the phone and they were doing things, but now they are completely passive. Either they're napping, they want to get into bed and sleep, and they literally do nothing, even though you keep telling them get up and do something. So, Robert is sharing sometimes during the day, mom will fall asleep and it's hard to wake her up while in her chair. Yeah, that can happen, especially when you're older, right? Our loved one has hearing problems too, finally going for hearing aids, so difficult to assess language. Oh, you are so right about that, Jean. And Dennis is saying all she wants to do is go to bed. So that's what we call a negative symptom, like a positive symptom where we actually see something. It might be agitation or restlessness or sleep disturbance. Those are kind of like active symptoms. A passive one, we're really not seeing anything, but it really is a symptom of the disease, and that's apathy. And that's like, think about those of us who are older. Remember the tape recorders that you used to hit the recorders to hit the start button for the tape to kind of play? Well, when you have dementia and apathy, it's like you have no starter button on your own. You cannot get yourself up and going to kind of do anything independently. You just have no will to implement any independent activity. So they depend on us. Like if we say, "Oh, here, would you come and help me with this?" then they might help us with that. Or if we pick up a ball and throw it at them, they'll catch it because we are kind of cueing them to do that. So many individuals will get very apathetic and they'll just sit there all day long and they won't do anything. And Yana is sharing that is my dad, smoking all day long and napping, end stage liver failure. I do believe dementia, really bad moods, then good moods, and repeating himself. So chances are, Yana, there could be a few things going on for him. He sits on the porch and he smokes all day. So yeah, sometimes individuals aren't going to engage in meaningful activities on their own because that's part of the disease. Um, Sometimes our family member might get irritable, right? And kind of be crabby with us, especially if we're trying to help them change a wet undergarment or get a bath or change their clothes. Sometimes they might be restless and they're walking around the house or they're trying to walk out the front door at 2 a.m. in the morning, or they could be aggressive with us when we're trying to help them or be aggressive with other people as well. So these are some of the mood changes that people can experience. Some of the behaviors, there might be wandering, there might be shadowing, that they're kind of following you around all day long. Does that ever happen to anybody? You turn around and they're right behind you. So you try to go to the bathroom to get a minute to yourself and they're knocking on the door. Where are you? When are you getting out of there? So they really have to be with you all day long because they're not sure where they should be or what they should be doing. So they keep looking to you for reassurance or confabulating. And sometimes caregivers talk about this, that, like, oh my goodness, my family member just keeps making up stories all day long. Like, I'll say, what happened to the tax papers that I left right there? And they'll tell me a big story about, something that happened to them when you know that they took those papers themselves. So sometimes people will start to fill in the blanks when we ask them information and they really can't remember. They'll make up a story that kind of makes sense to them to kind of appease us as well. So, and Dennis is saying that their person wants to hold my hand all day long. So they might need to be next to us to be reassured all day. So just some of the changes that we can see across a person with all of these diseases. Sometimes an individual with a dementia might start to have psychiatric symptoms, and that could be depression, where they're really tearful, where they're feeling, and they might be verbally saying this, I don't want to live anymore. I wish I was dead. So sometimes people do try to kill themselves, especially earlier on when they still have um, the mobility and they can kind of think things through because they feel really, really bad. They might be crying a lot. Sometimes depression in dementia is irritability and combativeness and aggression. So this is something that we really have to get checked out because there are medications that can kind of help with this. Sometimes individuals get really anxious and they might be like wringing their hands all day long or pacing all day long or saying the same thing over and over and over again because they are so anxious. Maybe they're not sleeping and they're just wandering all day long. So that's, pretty serious and we want to get that looked at. And then the third psychiatric symptom is a person could have psychosis. And there's a few different ways that that can present. And maybe you can relate to this. It might have happened to your family member at some point. Is psychotic symptoms could be hallucinations, and this involves our senses. So, this would be if your family member sees something that isn't there. Maybe they see children jumping on the couch, or they see small animals running around on your front lawn. We once had a family who shared that the mom kept seeing bugs coming out of the TV. So, those are visual hallucinations. Sometimes people have auditory hallucinations, which means they're hearing things. They might be hearing voices, or they could be feeling things, like maybe they feel things crawling on their body. That's like a tactile hallucination. Sometimes they could be smelling things. Once had an individual who kept smelling rotten eggs all the time. They were having an olfactory hallucination. So hallucinations involve the senses, and we can experience them in many different ways. Another thing that a person could experience are delusions, and these are beliefs, things that the person thinks are true that are not true. And a very common one for Alzheimer's disease is that if you're a married couple, the person who has the memory loss might think that their spouse is cheating on them, that there is some infidelity going on. So I once had a client Alma, she was getting ready for bed. She took her clothes off and she put them on the ground and turned to the bed to put on her pajamas. And then she turned back over and saw her clothes that she just took off on the ground and was insistent that her husband had another woman in the house because those were the other woman's clothes right there. So she was having some delusional thoughts. So, and Darlene is saying which disease is psychosis most associated with? Some people with Alzheimer's disease may experience some psychotic symptoms. Individuals with Lewy body disease will most likely experience some vivid hallucinations and delusions. So, some of them, more so than others. But these are things we always want to get checked out. So sometimes, like if your family member is saying, "Oh, I think that my husband's cheating on me," we might kind of be embarrassed to kind of talk about that with anybody because we might feel like it reflects bad on us. I want you to know here, this is just a symptom of the disease. It's a psychotic symptom. It's very common. Sometimes people could have delusions with Alzheimer's disease. They might think that there's somebody living upstairs and they hear them walking around all the time when really the person lives on a ranch and there's nobody upstairs. So that's a delusion too. Sometimes people might have thoughts that someone's stealing all their money, right? This starts to move over into paranoia. And that is when someone is out to harm me or hurt me or other people who I know or other people who I love. Maybe you're afraid that somebody's trying to break into your house or someone's trying to poison your food. I've had an individual who literally was so afraid he barricaded himself in his bedroom and put every dresser and bed that he could find up against the door so no one could get in there. We've had people call our line before to say, my mom is really paranoid that someone's trying to poison her and she won't eat any food. And her mom was a diabetic. So that was pretty serious as well. So, or sometimes an individual would say, my son Johnny, who lives in Pennsylvania, is trying to take all of my money when really Johnny has nothing to do with the person's money at all. So that can be paranoia. So if your family member is experiencing any of these, seeing, hearing, or feeling things that aren't there, having thoughts that are not true and you cannot convince them otherwise, or being paranoid and thinking that someone is out to harm them, we really want to get medical attention for that. So, and Darlene is also sharing, my mother thinks YouTube videos and photographs are talking to her. For some reason, that is very common, right? So, as long as a person is not being upset by what is going on, like if it's kind of mild and it's not really upsetting or impacting their ability to function and have a peaceful day, then we don't have to do anything about that. Sometimes a person might say, and I'll give you an instance about this as far as the hallucinations go. The woman who I mentioned kept seeing bugs that were crawling out of her TV. Well, her husband, he was so brilliant. He went and he got a can of Raid. He didn't take the lid off. He just pretended that he was spraying around the whole TV. So he would go over with the can and pretend to spray it. And it would make her feel better. And that kind of really reassured her. And then she would be all right. And she could kind of go on and continue with her day and watch TV and not be disturbed by that. That's a really great example. But it got to the point, like 6 months later, that that wasn't working anymore, so she really did need medication. And we do have medications that can kind of help turn that down. So, and Darlene is saying most of the time it brings her happiness. So, if they're believing something to be true, it's not upsetting them, it's not harmful, then we can just go along with that. If they're experiencing any of these symptoms and we're offering them some reassurance and they seem to accept it and it brings them comfort and they're able to go on and do the next thing, then it's okay. We don't need to get medical attention. But if it's really significant and there are safety issues and you're not sleeping, they're not sleeping, and you can't do what you need to do during the day, then we need to get this medically evaluated. So I don't have to preach into the choir here. Everybody knows that when we have these neurocognitive disorders, we can't do these basic things for ourselves, right? As time goes on, we, the caregivers, have to do more and more for the person that we are supporting as well. So now what's different is, and why we kind of want to know what the disease is, because the progression is different for all of the diseases. So Alzheimer's disease is very slow. People can live with Alzheimer's disease for like 20 years. So if you're older, maybe not so much because your body might succumb to something before the Alzheimer's gets you. But if you're younger, you can live with that for a long time. So it's kind of like a ski slope. You see how we kind of have the slope here? It's kind of slow and steady. So if you're living with the person, you might not even be noticing because things are kind of happening so slowly. If a family member visits from California who you haven't seen in 2 years, they might really notice because it's been so long since they have seen them. But Alzheimer's, slow and steady. Vascular dementia is very different. A person can be like kind of stable and going along. They at a plateau, they have a vascular episode and all of a sudden they dip because they had a stroke or they had some TIAs, and then they level off. They get physical therapy, speech therapy, occupational therapy. They kind of plateau and level off. Maybe 6 months later, maybe 2 years later, they have another vascular episode and it's a steep decline. And then hopefully they will plateau for a while as well. So that's more of a step progression. Um, a fluctuating example would be an individual who has Lewy body disease. And that means that the person could have more dramatic changes in their abilities and their cognitive functioning throughout like the week, the month, but even that day. Like some people have reported with Lewy body disease that like, oh, my mom, she's really pretty good up until 2 o'clock in the afternoon. Like prior to that, she's laughing, we're conversing, she's not upset about anything, but come 2 o'clock, oh my goodness, she starts to hallucinate. She doesn't make sense when she is talking. So for Lewy body disease, it can kind of fluctuate even within the same day. So, this is another reason why it's good for us to kind of know. And this is actually, we kind of look for these patterns because this kind of helps complete the picture when we are trying to diagnose someone as well. So, and Yana shared here, my dad thinks my stepmom is cheating on her. Not true. He always thinks my sister and I are trying to steal his money. Also not happening. And again, Yana, thank you for sharing that. That is very common. This paranoia and these delusions can be very common with the neurocognitive disorder. So we always want to keep our pulse on that. And we want to discuss that with our medical providers too. We're going to talk about what medical providers are best for us. And yes, you're so right, Yana. Most people think that it's just them, but this is just absolutely positively common. Not showering, common too. Anybody else, if that happens to you, type in chat and let us know here. Is there a death or catastrophic issue that dementia can Barb, I'm not sure what that means. You might need a different word there. Um, So Barb, just retype that because I'm not sure what that means. And Yana gets mad when we try to tell him to change his depends. That's true too. Yeah, 100%. People don't like to be told what to do, especially when it has to do with their own body and their personal hygiene as well. So, all right, let's kind of delve in here a little bit more. The first thing when we're talking about all the neurocognitive disorders, and maybe your family member did get this diagnosis at some point, but many doctors hand out the diagnosis. They might say, oh, your family member has MCI or mild cognitive impairment. Has anybody ever heard that from a doctor before? Type in chat and let me know about that. So, yes, okay, Beverly is saying yes. So, oh, Barbara's saying if a loved one has passed on, it can affect the person with the memory loss, right? It's hard for us to kind of process death, right? Yeah. So Pam and Claude are saying yes, that they've heard MCI before. So oftentimes a doctor at the early stages, before there is enough clinical evidence, a doctor might diagnose with a general diagnosis of MCI or mild cognitive impairment. And what that means is that when we look at the individual compared to peers their age of a similar educational level, this person is having some mild difficulties. And oftentimes, these are individuals who are self-reporting. So it's not like the family saying to the doctor, there's something wrong with my dad. It's dad saying, I feel like there's something wrong. The person's still functioning. They're able to do everything kind of for themselves, but they know that they kind of feel off a little bit. So before there's any significant things that are impacting a person's functioning, a doctor might give the diagnosis of MCI. Oftentimes, primary care doctors are slapping this diagnosis on everybody, all right? Primary care doctors are not the best people to be diagnosing the neurocognitive disorders unless they've had extensive training in working with older adults, like maybe they did a fellowship with a geriatric psychiatrist or something like that. But sometimes doctors are handing out this diagnosis just because they don't know the nuances. So if your family member received the diagnosis of MCI, I highly encourage you to every 6 months go back to the doctor and even go see a specialist. That's really, really important. And a specialist would be either a neurologist or a geriatric psychiatrist, as those doctors have special training to kind of tease out all the different diseases. So, because oftentimes MCI turns into Alzheimer's disease or it turns into Lewy body disease. So, as time goes on and the disease progresses in the brain, we can start to see more symptoms. And once we know about those symptoms, then it can point us in the direction of one of the diseases as well. So, if your family member has received this diagnosis, we want you to go back and follow up with the doctor and ask more. Tell me more about MCI, doctor. And I would like my family member to see a specialist, a neurologist, a geriatric psychiatrist to kind of get more information on that. So, um, Alzheimer's disease is the most prevalent neurocognitive disorder that gets diagnosed. So, and what happens with Alzheimer's disease? There are chemicals in the brain, neurofibrillary tangles and neuritic plaques that kind of go in and gunk up the whole brain. So, it's progressive, which means it's going to get worse over time. And it's global, which means that it's kind of spread to the whole brain. It's just not in one area. And let's take a look at a picture here. These are granny squares that a woman crocheted who has Alzheimer's disease. And just look at the difference in these. Can you see how things have changed over time? What do you notice here in the squares? What's happened over time? And Pam, hold on there, because we're going to talk about the tests that a person can get to kind of diagnose these diseases. The shape is changing, right? See how intricate they are when she started out here, and the colors change, the patterns are changing, and as things kind of go on, she's having a harder and harder time kind of reproducing the square, and she's probably done lots of these over her life, right? So this, kind of really displays for us visually how things kind of literally unravel for us when we have Alzheimer's disease in our brains. And if you're supporting somebody and you've been told that they have Alzheimer's disease, you can probably see this on different levels with all the things that your person can't do for themselves anymore. So remember, this is just one of the neurocognitive disorders. So we want to find out, does my family member have Alzheimer's disease? So, and again, oops, there are lots of different types of Alzheimer's disease too, not just one type of Alzheimer's disease. So there's early onset that you get prior to age 65. That's different than Alzheimer's that somebody gets when they're 80 years old or 85 years old too. And Yana is sharing the last one appears as though she doesn't recall how to crochet correctly any longer as she did. That is so true. And that's what happens, right? We lose the ability to do the things that we were once so good at doing. And it starts to trickle to every area of our lives when a person has Alzheimer's disease. Now, vascular dementia, how is this different? So, Vascular dementia is when we have a stroke, when we have a loss of blood flow from the heart to the brain. It wasn't pumping and we didn't get the energy and the oxygen up there. So a part of the brain died where we had the loss of blood flow. We can see that when we get neuroimaging, when we get MRIs or CAT scans, we can see that. So it's always important to get that done. You can see where those strokes happen. If they're TIAs, it might be harder to see because they're very, very small, but over time, we might start to see more little white spots in the brain, and the white spots are where the brain lost blood and then that area is not functioning well anymore. So somebody for with a vascular dementia, remember we talked about Alzheimer's disease, how it gets to be profuse. It goes through the whole brain, like the chemicals start to gunk up the whole brain. Vascular dementia is going to be different. It's going to be very pinpointed. So there just might be some areas where the person has impairment. Maybe their language a little bit, maybe their short-term memory. Oftentimes it happens with the short-term memory, but the person with vascular dementia, they might still have a full vocabulary and be able to converse with you. So that's how it could kind of be a little bit different. Whatever is good for our heart, we have a little picture here of like the brain and the heart kind of holding hands. These are in constant communication with each other. So if our heart is challenged, our brain's going to be challenged too. And so we want to keep the heart healthy so the brain can stay healthy. So we can have a stroke, um, and we can get all the therapies, physical therapy, speech therapy, occupational therapy, and we can regain a lot of our functioning. But we want to make sure that we're doing the things that the doctor is recommending to keep our heart healthy. So to reduce our risk of having another stroke as well. So I know my dad just had He's had a bunch of TIAs, like one after the other. So, and the doctors are working on his meds, and we keep telling him, get up and walk around, eat a healthy diet, stop eating ribs, eat healthier food. You want to do everything you can to kind of support your health so your brain can stay healthy, even if you already had an episode in your life as well. So that's vascular dementia. And keep in mind, like we said before, a person could have a mixed dementia. So I might have Alzheimer's disease and I could also have vascular issues and I might have also had a stroke. Or I might have Alzheimer's disease and be at risk of having a TIA too. So it's really important to keep our heart healthy. Even if we have a neurocognitive disease, we want to do what we can to support our heart health. So, another disease is Lewy body disease, and this is different than Alzheimer's disease. We talked about Alzheimer's disease. We have neurofibrillary tangles and neuritic plaques in our brain. Lewy body disease, it's a different chemical, and they're called Lewy bodies. And these are all named after the doctors who kind of isolated all of this. They looked at a brain biopsy and they saw the slides. So the doctor who differentiated all of this, his name was Louis. So they're called Lewy bodies. So, but it's a different chemical in the brain. And uh, l- um, Lewy body disease, as I mentioned before, people can be prone to having lots of hallucinations and lots of delusions. And the language may be more preserved. So the individual can tell you in detail about these awful, scary hallucinations and delusions that they are having all of the time. And they could have fluctuating cognitive abilities throughout the day as well. Individuals with Lewy body disease may have what we call Parkinsonian symptoms, which means that they could get really stiff in their arms and their legs. So they might have a hard time getting up from a chair, or they might start to shuffle, have a shuffling gait and not pick up their feet. It might be hard for them to go up and down steps. They might kind of freeze while they're trying to put on their shoes or put on their pants, or have a hard time getting the shirt over their head as well. So a person can kind of have motor symptoms with that too. And with Lewy body disease, the progression can kind of be faster. Like Alzheimer's disease, we said it could be 20 years or so. With Lewy body disease, it could be much shorter, like 3 to 5 years, and it could be more aggressive. It could kind of, happen a lot faster and be much more challenging for the individual as well. So Now, some people who have Parkinson's disease, which is another neurological disorder that impacts our movement. If you've ever seen somebody who has Parkinson's disease, they get really stiff. They have a hard time kind of moving. They might have a hard time articulating speech, even using the muscles in their face and their tongue to kind of articulate speech. They might still fully understand what we are saying to them, but they just might not be able to get that out there as well. So some individuals with Parkinson's disease, especially if they get Parkinson's when they're much older, like in their 80s, if you live to be an older age, you're more at risk of developing memory loss as you get older with Parkinson's disease as well. So Lewy body and Parkinson's are kind of similar in this, that there can be a motor component that goes with that too. And that's why we kind of want to know what the disease is, because individuals with Lewy body disease who are going to have the hallucinations and the delusions, they're going to need medication so they are not tortured by the hallucinations and the delusions. If you go to a primary care doctor, they might be quick to write a script for an antipsychotic. There are lots of different antipsychotics. Some of them people with Lewy body disease do not do well on at all. It can make their situation worse. So that's why it's best to go see a specialist who specializes in these diseases and older adults so they can prescribe the right medication to alleviate the symptoms and help the person have the best quality of life as possible. So we're just going over these in a nutshell. And I have other handouts that I'm sending to you too that's going to describe these more in detail, little charts and everything to kind of help you understand the differences as well. There's another type of neurocognitive disorder called frontal temporal lobe dementia or FTD. So just may go back for a minute, like remember Lewy body disease. Robin Williams, right? It came out in the news that he was diagnosed with Lewy body disease. So, and then when we think about frontal temporal lobe dementia, Bruce Willis is in the news, right? His family has been pretty public that he has FTD. This is a little bit different. Whereas we talked about Alzheimer's disease is all throughout the brain, neurofibrillary tangles and neuritic plaques. Lewy body disease is Lewy bodies are in the brain. Frontal temporal lobe dementia, different chemicals are in the brain, and it's going to impact the front part of the brain, the front part and the temporal lobes here on the side. And what's in the front part of our brain here, that's kind of our social controls. So, and our judgment. And our filter. Oftentimes, people with FTD can be really inappropriate, say inappropriate things, do inappropriate things in public. So we all think things, but we kind of stop ourselves and say, oh, this is not appropriate to say this in public. I'm just going to keep that to myself. Oftentimes, people with FTD are just going to say it because the filter is impaired from the front part of the brain. They can get themselves into trouble in public. Sometimes they might engage in things like shoplifting, or they might be sexually inappropriate with other people in public and be touching them, or something like that, or disrobing in public. So, FTD can strike people when they are younger in their 50s. Maybe they're still working, and then maybe their family or their coworkers think, "Oh my goodness, what's wrong with this person? They're really acting in kind of bizarre ways." It could be due to FTD. So again, a different disease. The symptoms are a little bit different. It strikes people when they are younger, and it can kind of be a quicker progression as well. So I'm covering a lot of these diseases here right now. I'm just going to pause to see how's everybody doing, and does anybody have any questions about what we've covered so far?
I find it to be very informative and it causes me to think in a different direction. Thank you for arming me with more information because when I go into the doctor, instead of that 5 minute in and out with the doctor, it's going to be a little more like 20 minutes,
Yeah,
you know?
good for you, Robert. Yeah. Listen, doctors think that we don't know stuff, okay? You're being empowered here right now. You know right now. So you're going to take all this. You're going to take the handouts with you. You're going to take the brochures. You can show the brochure to the doctor and say, "Hey, I know there's lots of different types of dementia. I want you to tell me what dementia my family member has. And if you don't know, I want a referral. If you need a referral, mostly these days you don't need a referral. You want to go to a specialist so they can explain this to you as well. So they're all different. This is what really, I don't know what the word is. I always say grind my goat, but I don't even think that that's a saying here. But it really gets under my skin when people write us off when we get older. Stop writing us off. Medical professionals write us off. We want workups. We want people to explain things to us, and we want to make sure that we have access to all the treatments that are available so we can have the highest quality of life until the day we die. Okay? So that's the goal here. We want to be empowered so we can take care of our people. So, and Yarma is saying, yes, the doctor should be a neurologist or a specialist psychiatrist. 100%. So those are the differences. I think everybody's on board now. You need to know what your person has so you can get the best treatment. And so you can plan for the future. If your family member has Lewy body disease, if they have Parkinson's disease, you've got to start to plan for that because you know there's going to be a lot of motor complications. So you might have to start to get grab bars in your bathroom. You might have to get a bar going up and down your steps. You might have to get a chair lift. You might want to think about, I don't have a bathroom downstairs or I don't have a shower downstairs. Maybe I'm going to renovate and I'm going to get that put in right now if you decide that you want to be able to provide care at home. So, knowing what it might look like in a few years can kind of help you plan now. So, that's why you want to know. And basically, it is going to improve the quality of life, not only for the person that you're supporting, but for you. Okay. Like if you know that within 2 years or 3 years, your family member isn't going to be able to get themselves from the chair to the toilet on their own, you might start to think about what's my plan for getting more help in here because I can't do everything on my own. Okay. So it's going to help you think about that. So, geriatricians, thank you, Darlene. Vote for geriatricians 100%. A geriatrician is a doctor um, who can provide primary care so they can like kind of oversee everything, but they specialize in older adults. So when we get older, our body is different than when we are younger. Remember, Yarima pointed this out earlier. When you get a UTI and you're younger, it looks completely different when you're in your 80s or your 70s or your 60s. It can impact us differently. Our body metabolizes medication differently as we age. It stays in our system longer. We have a harder time of getting rid of any negative impacts of medications as well. So things that we were on when we were 20 medications, we may not be able to tolerate them when we are older. So general primary care physicians are not versed in older adults and what are best for them and all the side effects. Our balance can get challenged as we get older, even if we don't have a neurocognitive disorder. So many medications impact our balance. Lots of medications that are over the counter or that doctors would prescribe for normal things that happen to us as we get older, even like bladder medications. Males or females might have overactive bladders as we age due to changes that we're going to experience due to atrophy. Doctors might prescribe medication to help that bladder. But guess what? Those medications can impair us cognitively and be worse for us. So we need to know about that. If you go to see a geriatrician, they're going to know about this stuff. They're going to look at all your conditions and all your medications, and they're going to come up with the best plan to kind of optimize all your organs and your whole quality of life, too. So geriatricians are the best. I really suggest, Barbara and I would suggest that find one and switch your care over to them because they really kind of give you really good services. So many geriatricians will be equipped to make a diagnosis because they have this special training. Many of them might be hooked up with like memory care centers, so they're a part of a team there, so you'll get that extra attention too. But if not, the good next best people to go to a geriatric psychiatrist because they specialize in the brain and also older adults. So they are very specialized in this area. That's who we have at our clinic. It's a geriatric psychiatrist. Look for a memory disorders clinic or a geriatric assessment center. Those are great places too because they're going to have a whole team of professionals who can kind of look at it from lots of different perspectives because that's what we really need. Not just one viewpoint, but we need like kind of wraparound care here. And Barbara says, my husband went to his geriatrician today, spent over an hour. I love that. So geriatricians usually give you more than 5 to 10 minutes, right? So think about that. And you can call us at Care to Caregivers and you can ask us, we can help you find a geriatrician in your area as well, or a memory assessment center too. So you can get that diagnosis for your family member as well. So, but these are the things that the person who you go to see should be doing to get the diagnosis. You need the medical workup. You need a full medical checkup, blood panel with all the labs that you can possibly get. You need urinalysis is really important too. So, neuroimaging, oftentimes that will be suggested well, like PET scans or MRIs or CAT scans. Those are really important as well. So, first you go see your primary care doctor, you get all that information, then you go for your memory evaluation. Now, when you go for the memory evaluation, they're looking at lots of things. They're looking at your medical history, they're looking at did you ever have a head injury? Because that can impact our risk of getting dementia later in life as well. They're looking at your labs to see how everything is with that. Some medical conditions can impact our cognition as well. And then a good evaluation, they are going to ask you 500 million questions. They're going to say, tell me about your mom. When did you first start to notice problems, like with her cooking or with her dressing, or when did she start to get lost? And can she use the remote controls for the TV? Or is she having a hard time operating the microwave? They're going to ask you tons of questions. And these are like functional assessments to see, can she dress herself? Can she cook for herself? Can she pay her bills on her own? So the more information we know, the better we can make a diagnosis. And Claude is asking, is the Ramapo Ridge Hospital a place to get a dementia evaluation? Claude, I don't know right now. You can call us at Care to Caregivers and we can check that out. But I know they have lots of good programs up there. I'm not sure if they have a memory assessment center. Chances are, I think they probably do. I think they have an inpatient psychiatric center. So hopefully they have some doctors there as well. So, but anyway, it's just not one thing. This is how we diagnose. We look at the history, we look at neuroimaging, we look at the labs, we look at the patterns over time. Has this been like fast? Has it been a marked steep decline in functioning? Because remember, we talked about vascular or kind of steep steps, or is it a slow kind of gradual things that they just start to have more and more difficulty with things over time? Are they having lots of hallucinations? Are they having lots of delusions? A physical exam. How stiff are the arms when I try to move the arm? We watch the person walk. The psychiatrist will watch the person walk because they're evaluating their motor ability. So we look at all of these things to kind of give us a diagnosis. There's also a new blood test that just came out for Alzheimer's disease as well. And none of these things are meant to be used in and of themselves, but they're all a part of getting a complete picture of the person. So does that answer the question for everybody? Or maybe Darlene or somebody asked that a little bit earlier. How do we diagnose? We diagnose by getting ourselves to the right professionals who do a thorough workup. It should take an hour to two to kind of get lots of information. And you might not even get the diagnosis at the end of the one appointment. You might need to have two appointments, like you go back in 6 weeks for another appointment as well. So type in there if anybody has any questions about diagnosis, please. Or Robert, did you have a question? You just put your camera on.
Oh, no, but I want to look into the JFK Neurological Center that we have here in Edison.
Good, good, perfect, good.
I think
So
that'll be a good start. Thank
good.
you.
And then once you do go to the doctor and you do get the diagnosis, don't stop going back, keep going. Okay? Because you always want to get your person followed up. They can monitor how fast are things progressing. They can rule out that there aren't some other underlying physical or medical things going on that are kind of complicating your picture. And then they can advise you on things that are there to kind of support you as you're going along as well. So keep going back to the doctor. It's not a one and done, okay? And
Thank
Mary
you.
is saying any recommendations for convincing loved ones to get more extensive diagnosis by the specialist. Yes, Mary, that's a problem because, hey, who wants to go see a psychiatrist? If you told me I would have to go see a psychiatrist, I might say, I'm not going there. I'm not crazy, right? Nobody wants to go there. If that's your family member, then we just don't present it like that. We say, hey, our new health insurance has a requirement that we all have to go and get a checkup once a year. So, and we don't have to say we're going to a psychiatrist. We don't have to say it's a memory evaluation. We just have to say this is a new requirement for our health insurance. So think about that. All right. So just think about that. Being still for the MRI is very hard for her. Well, chances are not everybody needs an MRI. If like my dad's 92 years old, he has heart disease, he has diabetes, he's had multiple strokes. He does not need an MRI, okay? Putting him through that is not going to give us any information that we don't already have. So we really need to think about that. You talk with your team to decide what type of testing is best or not best for me. Now, if it's a younger person, somebody in their 60s, or if it's somebody who's in their 70s and maybe they're just having some mild symptoms, and we're not sure and we really want to know, another thing that happens is you can go for neuropsychological testing. And that's a whole different specialist who you get referred to, and they will ask you questions for 2 to 3 hours. So, like, they'll say, name how many start naming animals, and they'll count how many animals you can name within a certain period of time. They'll tap out a pattern with their hands, like drumming on the table, and they'll ask you to repeat after them. So there's tons of memory tests, and pretty much they can get a good sense from the testing that they do with you what areas of your brain are impacted, and we can use that to give us a better picture of what the disease might be as well. So goodness gracious, everybody, we only have like 15 minutes left here. So I'm going to kind of speed through some of this stuff as well. So the test depicted on the slide is really telling. And Yarma, I'm not sure what that means here, but oh, here as far as I'm not sure which slide you mean, Yarma, but let me know. Blame it on the blame it on the insurance. Yeah, Robert said blame it on the insurance to tell mom, oh, we have to go here. It's a new requirement from the insurance, right? So yeah, and we don't you kind of, as far as how forthcoming are we with our family member? If it's really upsetting for them, I mean, my viewpoint is I kind of want to protect them as much as possible, right? Some people want to know, and you kind of know for your family member, like you want to say, yes, we really think you might have Alzheimer's disease or something like that. And we're going to go to the doctor for that. That might work for your family member. For some people, it just might not work. I one time had, when we had our day program, I had a son-in-law bring in his mother-in-law for our program, and she had Alzheimer's disease, but she didn't know she had Alzheimer's disease. I think they had told her before, but she couldn't remember that, and she didn't have insight into her situation, which is very common because that's in a part of the brain as well. Oftentimes, individuals with neurocognitive disorders aren't aware that there's anything wrong with them. They think there's something wrong with us, saying that there is something wrong with them. So when she sat down in my office and we were just chatting, I never say like Alzheimer's disease or anything like that. She happened to see our brochure, which was sitting on the table, and she picked it up. And it said like, Alzheimer's disease. And she's like, what is this? I do not have this. I am not coming here. And she stormed out. So she was so very, very upset. Well, needless to say, the family was able to convince her to come to the program because she forgot that she saw that in my office. So, and she was with us for years. But, at our program, we never said, oh, yeah, you're coming to the Alzheimer's Day program. We never said that. It was the senior club. So because we don't want people to feel bad about themselves. So and when people would, say that, they were having problems with their memory, we would say, "Ah, we're all having problems with our memory. We're all getting older and things are a little bit harder for us." So we would kind of normalize it for them so they didn't feel bad about themselves. So you kind of have to play it by ear for your family member and what's going to kind of work for them. Had another caregiver once, and it was so sweet. Like for her and her husband, the way they talked about it was whenever he was cognitively kind of feeling off a little bit, they wouldn't say, "Oh, yeah, that's your Alzheimer's acting up." They would just say, "Oh, yeah, your allergies are bad again." So he knew he was kind of off, but it just seemed just kind of a kinder and more comforting thing to kind of talk about it like, your allergies. So you kind of really have to think about that for yourself, what's going to work best for you. And yes, we do the blood, that's just within the last few weeks. There is a blood test that's out. There's a spinal test that people can get to, but you really want to talk with a specialist about what is best for your family member, based on their presentation. But we can tell a lot and we can diagnose a lot while the person is still alive as well. So now we know for the individual with these neurocognitive disorders, there's different stages, right? It goes from mild to moderate to severe. I hate to kind of peg anybody in any place because sometimes some parts of us are mild and some things might be more impaired, but just to know that even as our family member is going through the different stages of progression of their illness, we're going through different stages as caregivers too, right? So at the beginning, we could just be really busy trying to figure it out and make appointments and fill up pill boxes and stuff like that. But as time goes on, we might be grieving. We might be grieving for who the person used to be, and they're not the same anymore. And our relationship has really changed as well. And there might be more of a physical load for us, more things that we have to do as they're less able to do things for themselves as well. So we want to keep a pulse on ourselves and say, how am I doing as this is progressing for me as well? So we want to make sure we have the support that we need. I know you're going to do what your family member needs to get them what they need, but we want to make sure you have what you need as time goes on as well. And that's why we're here. We're here to support you to help make sure you have all the supports that you need so you can be all right as you're providing care as well. So we don't have a whole lot of time for this, but I just want to quickly go over this. That we're not going to have time for that video, but that there are some things, medications that we can take. We do have some medications out there on the market that are FDA approved that may improve cognition and help delay the progression of these diseases. And Yarma is saying it's like a slow death. You're right, Yarma. Yeah, we all have a slow death because we're all going to die, right? So, but the individuals who we're supporting who have these neurocognitive diseases, we know exactly what part of the brain is or what part of the body is impacted, and we know it's going to go a little bit quicker for them. But there are some medications like Aricept or Namenda or Exelon. There's the new infusion drugs that are out there too. For people who are early on in the disease process, they might benefit from those as well. So, there are antipsychotics. If your family member is having hallucinations or they are delusional, they need medication. We have safe, effective medications that can calm down that part of the brain so the person cannot be tortured because it's torture and suffering to have hallucinations, delusions, and paranoia. So we want them to get relief from that. We have safe and effective medications if your family member is depressed, and sad. They can take a low dose of an antidepressant and really have improve in their mood, and anti-anxiety medications as well. So this is why you want to see a specialist, a geriatric psychiatrist or a geriatrician to be prescribing these medications because typically primary care doctors are not versed in what's best for older adults. If you walk in to see your primary care doctor and you say, "Oh, my mom is anxious, she's walking all day," and then she's up in the middle of the night, they're going to be quick to slap anti-anxiety medications and sleep medications on you, but they could all really have a negative impact on your person's cognitive abilities and their motor abilities, which might make them more prone to falling. If they fall, break a bone, wind up in the hospital, rehab, and they might have to go to a nursing home and they might not be able to come home. So medications, the least amount, the short amount of time with the least side effects so the person can stay safe and maintain a good quality of life. That's why we want to go see a primary care doctor. Now, medications cannot help all of these things, okay? Disorientation, memory problems, language, wandering, sundowning, hoarding, poor social judgment, all of these things here, repetitively asking you the same questions over and over again, being able to find our way to the bathroom in our house, apathy. Medications can help these things. So that's where we come in and doing other things that kind of support the individual. So that's where having a good structure in the day, having meaningful things for the person to do all day long is really, really important. Adult day programs are great places if your family member has a neurocognitive disorder where they can go and participate in therapeutic activities. There are professionals who are kind of prompting and inviting them all day long to do things that are really fun for them. Getting exercise and moving and walking, us providing reassurance and redirection is really important as well for them. And then just making sure that they have what they need so they can have a good day. So I'm not saying that everybody has to be busy all day long, but if your family member isn't doing anything, that's not good for them at all. Things like music are really, really important. Having your family member engage with things like music or having them do creative things, little art activities as they're able to, with you supporting them as at home as well. Um, and yes, medication can work, and your loved one loves music. Music is really, really important. So I did have a question too. I think Olinda is here with us. You had emailed me and asked me about the Nassau music. Has anybody else heard about that? So, and that's a special kind of music, like kind of sound that I think from what I saw, you could purchase that. So there are all types of things out there that people might be trying to market to us, so we always want to kind of look into that. There's not a whole lot of research that I saw on that yet. You have to look at the research that is out there, and sometimes if the research is just done by the people who are trying to sell you the product, then you have to kind of think about that. But music 100% is beneficial for all of us until the day we die, right? Music is preserved in a part of the brain, even when a rest of the brain might kind of be impacted. People who can't talk anymore still might have the ability to fully sing along to a song, and they can remember all of the words because that is preserved in another area. So but doing things to kind of support you. And our friend also asked about something else about grounding techniques. So maybe you've heard about that, like you hear people talk about grounding, and that means going out and touching the earth. Maybe you hear people talk about take your shoes off and go out and stand on the ground, or go put your hands on a tree, and that can be a grounding activity as well. So, being with nature can be very grounding for us. These things are free, right? We can get out there and have access to them. There's really no harm in being connected with nature. There's really no harm in engaging with music. So you kind of have to try these things. You have to try all these different activities to kind of give your person kind of a meaningful and stimulating day on a way that is appropriate for them. I'm sending everybody a good handout that kind of summarizes everything we've talked about, lots with lots of other things as well. So, and anybody call us at Care to Caregivers today so we can help you find what you need to find as well. So I'm yakking on here a lot about everything, everybody, but I want to show you one more video as we are wrapping up here. Okay, now remember at the beginning, oh, and also for those of you who go to our support groups, I know you know about this. Medicare pays for occupational therapy, speech therapy, physical therapy, and nutritional consults. Use this, okay? Talk with your doctor. Occupational therapy, physical therapy, and I think even a nutritional consult. You can just call your insurance and book the appointment on your own. Speech therapy, you might need a referral from your doctor, but individuals with neurocognitive disorders benefit from all of these things, not just once, but all the time. So sign your family member up for occupational therapy. They can kind of help you figure out how to better take care of them in the home. And then when you're done with that, sign them up for physical therapy to help get them stronger for walking. And when you're done with that, sign them up for nutritional therapy. Their ability to kind of chew food or digest food might change as time goes on. So keep these things kind of rotating. This is another way to get some additional support for your family member as well. So let's go back. Remember the video that I showed you about Janet and when she was asked about what kind of trees she has at her house and she couldn't remember? Well, let's look at this video now.
While it's important to understand the cognitive deficits that impair people with dementia, it's also important to understand the strengths that are preserved. These strengths include sensitivity to emotional environment, social skills, ability to participate in tailored activities, ability to learn routines, personal skills, and redirection. By using these strengths, we can maximize the functioning of day program participants and help to manage behavioral problems that might occur. Preserved strengths are a source of self-esteem and identity. Janet has trouble understanding what she reads, but she is fluent in reading and gets satisfaction from being able to do so.
I think that I shall never see a poem as lovely as a tree.
So did you notice that? Remember before when Janet couldn't say anything? Remember that? But look at that. She could fully read a poem. So, and her voice was beautiful. So we want to think about that for the individuals that we are supporting. Yes, there might be things that they can't do anymore and they can't do the things that they used to be able to do before, but there still are things that they can do. And that's our job as a caregiver. And I know we can't do that alone, so we're here to kind of support you in that, but we can help you think of activities and things that you can do. But let's celebrate what the person can do. And let's celebrate, like Yarma mentioned that earlier too, that the love is still there. We can still stay connected and the relationship's going to be different. The engagement is going to be different. But, think about yourself. If it was the tides were turned or it was reversed and I was the one who had the memory loss, how would I want people to engage with me? I would want them to keep engaging with me. I would want to know that I'm not alone and that people are still there for me. Even if I can't communicate, I would kind of want to feel them that they hadn't given up and they were there for me. So that's really, we got to all strive towards that, everybody. So we're here with you as a team to kind of help you get there. So, for caregiving, what can you do? Empower yourself. Number one, pat yourself on the back right now because you are here and you are learning. Okay. This is an ongoing process. Share, talk with other people, go to support groups, call us at Care to Caregivers, talk with your family and friends. Let them know what's going on for you. You got to get this out and you got to kind of build your community, right? Ask for help. Ask us, ask the people in your life, hey, I need help. Can you come over on Tuesday night? I want to go to the gym or I want to go to the movies with my friend. Do things for yourself every day. Make sure you're hydrating yourself. Make sure you're getting good nutrition for yourself. Take yourself for your doctor's appointments. Hang out with your friends. So you need to keep well on yourself as well, right? So take care and then look for the good. Yeah, things might not be the way that you want them to be or the way that you expected them to be. But when we focus on what's going wrong, that kind of takes up more and more space in our brains. So lots of science and research behind this now. Focus on what is going well. I have a roof over my head. I have medical care. I have people who are supporting me right now. So think about those things. That can kind of help us get through these really challenging times. So, and just a little quote here as we are wrapping up here, which kind of helps us stop us end on a positive note here. To love a person is to learn the song in their heart and sing it to them when they have forgotten. So that's what we're trying to do here, right? We're still there. They might be forgetting. We are not forgetting, and we are there to kind of hold them in a safe place and hold ourselves as in a safe place as we go through this together. So I want to thank everybody for being here. I really appreciate your attention, appreciate your participation. I'm just going to stop the recording right now in case anybody has any questions. Okay, so just pause with me here for a minute. Okay, um, so pause the I think I paused it. I think I'm paused. I'm not sure here, folks. So, I'm going to send a follow-up email when we are done here. All right. So if you have any questions, you get back to me about this. I ask you to take a minute and give us your feedback on today. We are grant funded, and our grant funders like to hear how we are doing. So reach out to us. We are here to support you for anything that you are going through. And I'm just gonna stop sharing right here, and then I'm gonna open it up. Does anybody have any questions? I know we covered a lot here, and we've been here for a long time, but this is a big topic. So anybody have any questions or anything that they want to share as we're wrapping up here?
My compliments. What a magnificent presentation.
Oh, thank you, Yarma. Thank you.
And I second that. Mary Catherine, you are phenomenal.
Oh, thank you. It's a lot to cover here, everybody. All right. So I could talk about this for 48 hours straight, but at least it gives everybody like a little intro into it.
Thank you.
Good.
Yes,
Anybody
thank
have
you.
any questions that they want to ask the group, or things that they want to ask me, or things that they would like to know more about that we could plan for a future event?
I just have a question about the therapy, the four areas of therapy.
Yes.
Medicare is our primary, and we do have a secondary, and Medicare seems to limit it to 30. And are those four areas that you mentioned, are they under that umbrella of the 30 visits?
You would have to call your insurance to
Oh,
check,
okay.
Mary Ellen, okay? And it might even be based on what the issue is. Like if you're getting physical therapy for your hip, and I don't know this, but you might get a certain number of visits for that. But then, like if you know your arm, you have problems with your arm, then you might get other coverage for that as well.
Okay.
So,
Thank
but the other thing too that we always want to stress, something to encourage you as you're talking with professionals and trying to get your family member um, approved for something. Don't minimize what's going on. You know, sometimes when we're applying for a screening program or something like that, we're like, oh no, she's fine. She can go to the bathroom by herself, or she can dress herself. When in reality, you're in there. You know, you're spending 20 minutes in the bathroom helping her use the bathroom, or you're helping, taking, he can't get a shirt on and you're helping him get a shirt on. No, he really can't do that on his own. So we don't want to minimize it. We really want to tell the truth about no, they really do need help, or no, she has a really hard time walking up the steps. She can't get up and down the steps. So you got to tell the truth about that. All right. So you can get approved for some of these things. Don't minimize anything.
Okay. Thank you.
Anyone else? Any questions? Anything that you would like assistance with? Things that we might have missed?
Is there,
Robert?
would I be able to go back and run this course over again?
Well, I not videotaped it. I recorded it today. So
Mhm.
I will send everybody the link to the recording. It just takes a while for that to download. So by the end of
Oh,
tonight, I'll
perfect,
send everybody the link to the recording.
Excellent.
perfect.
Okay. But
Thank
you
you.
are, I'm telling you, you're going to get quite a few handouts that are going to summarize everything so you can look at overall. Okay.
Keep it coming.
All
There's no
right.
limit on information. Thank you.
All
And I'm
right.
so
Good.
glad I
Thank
found this
you.
with you guys.
Good,
Thank
good. I'm glad you found us too, and just everybody keep looking, okay? Just keep putting it out there, keep reaching out. One person connects you with another person. And Jean is saying would like more information on strategies for helping with difficult behaviors. My colleague, Dr. Angelica, is doing her next webinar on that, and
yes.
that's on July something or other. I don't know the date. It's at the beginning of the month. But when I send out the follow-up email to you, there'll be the link to sign up for that webinar too. So please attend that webinar, okay? July the 2nd, Darlene saw that. So sign up for July the 2nd, okay? So you can attend that webinar as well, all right? But even in the meantime, call us at Care to Caregivers. If you're having a hard time getting mom into the shower, or if dad is wanting to leave the house at 2 a.m. in the morning, call us and talk with us at Care to Caregivers, and we can help you strategize on the particulars of your situation. So anybody else, anything that I can help you with here today? All right, everybody. Well, keep coming. All right. Call us on the line if you're not attending a support group and you would like to attend a support group. Those are great places to learn. We pick up so many good tips from our friends who are walking in the same shoes that we are. I'll send out information about the support groups in the follow-up email as well. Come to the support groups because that's a great way to build your community, your village, and continue the ongoing learning as well.
Please
So,
accept hugs from my
oh,
wife and me. We're sitting together watching.
oh, wonderful. Thank you. Thank you. So glad you are together. And thank you for being here. Thank you, everybody, for your participation. And everybody, have a wonderful rest of your day.
You too. Thank you. Ciao.
Be well, friends. Thank you.
God
Bye
bless
bye.
all of you. Bye bye.
Thank you. Bye bye.